this company that loaned us this instrument, representative of this company located in California, Dan Henry. So he was kind enough to give us instrument for a few days. And if you need some information, he put also some brochures there. Feel free to pick up it, of course. As you can see, it is a really small portable instrument. It's called Doppler Box X. So you connect box with laptop, the trans software, and then you have probe holder, which is so-called low-profile probes that are actually moving in any direction, as you can see. All right, we can move up, down, left, right, and again here you can. Usually, again, when we are doing patients, it's very simple explanation. Esther, I will do now for you.
Okay.
Monitoring test. All right. Yes. No pain, no needle. We will be listening brain wave. Okay. All right.
Only stroke that we haven't developed.
Good. Good. What we are doing, by my opinion, most unpleasant part of the whole test, it is gel that we need to put on patient's hand, all right? So let's do it, all right? Here we have knobs so we can adjust, right?
It's fine. I'll look through this.
Huh?
It's okay.
It's okay?
Yeah.
All right. So I'll put some gel now. And of course, if you are in OR or inpatient, outpatient, gloves, right?
I wanted to see where the so one's behind the ear and one is in
No,
No, they're gonna move.
no, we will move that.
Oh, okay.
It is not yet done, all right? And again, they put a relatively new software on this machine, and when today I tried to run and I had some problems. So usually, of course, as you can see on the screen, you can have right MCA, left MCA, all right? And you can run script. One of the great advantages of all contemporary TCD units, they have right. Here we have upper screen where we will see a regular Doppler spectral waveform, all right? At the bottom here, what we are seeing, it is so-called power and mode Doppler. What is difference between two of them is the following. Y-axis here represents flow velocity in centimeters per second. Y-axis here represents depth of insanation, all right? Of course, x-axis times here times there, all right? Why it is important to have depth of insanation? Because if vessel is circular villus are aligned in one horizontal plane, you can see all of them. And then you can just moving this cursor here, and you can measure flow on one depth, second depth, and third depth. Just to give you a little bit more insight of TCD technology, how would you know which vessels were insanating, all right? What was done at the beginning of TCD application, physician took 40 cadavers, okay. They took simple ruler, and they measured distance between surface of the skin to MCA M1 segment, to MCA M2, to ACA, ICA, etc., etc., etc. So among different criteria, different depths of insanation. And with power and mode, all machines now have them. We have ability to see this depths of insanation. So you can see now, for example, vessel here, here, here. Based on the depth, you will assign this vessel to M1, to M2, to C1, to A1, etc.
Depth of what you said?
Insanation. Depths of insanation using ultrasound probe. What is big while we had problems with transcranial Doppler, not problems, we did not use it. We use carotid Dopplers, we use ultrasound for small parts of the body, etc., but we never able to use transcranial Doppler. Why? Because all other type of ultrasound works on so-called continuous wave technology. Right? That did not give you depth where you put in your sample volume. So what Dr. Rune Aslid from Norway with his colleagues from Switzerland did, they invented TCD in 1982. It was first publication in Journal of Neurosurgery about TCD. How they did it? They created pulsatile waveform. So 2 MHz probe the tester has now here, they're working with pulsatile repetition frequency. What it means, when gates open an ultrasound, it goes based on the time it goes for 2 centimeters, for 5 centimeters, for 10 centimeters, etc. So it is main reason when we are doing TCD we need to use pulse wave technology. That will define based on PRF, pulse repetition frequency.
Got a plan if you need.
Because I tried to go from
Is it the top one? So on the left side we are on the depth 50, which corresponds to M1 segment of the middle cerebral artery. Now what we need to do, we need to find vessel, right? And of course, when you are trying to find vessel, you need to look on the screen and listen. Because initially what you can start hearing pulsating sound. What are you yesterday? I'm 36.
I'm good. Because usually in young people it's relatively easy to find window to the brain when we have less thick bones.
There it is.
So we found QMCA. We need to do a little bit more. As you can see, we have a relatively big sweep time, better to change sweep time, low, so yes. Depth 50 millimeters, 5 centimeters, which correspond middle segment of the M1 segment of the middle cerebral. It is very close to
Contralateral is much more closer to the much more shallow depth. You see, she moved and we lost signal. And again, we are of course not in perfect situation, but we'll try again. So now it is almost perfect. The sweep time didn't change. So I changed sweep time. Why change sweep time? We have more time on the screen and you can see what is going on. And again, we talked with you about so-called cerebrovascular reactivity testing, for example, which is secondary indication of the status of cerebral blood flow autoregulation. And for example, we can ask Esther now, breathe normally at one, and then just stop breathing and hold breath. Don't breathe.
Want me to stop now?
So she stopped breathing, what will happen, CO2 will go up now. And what happened with middle cerebral artery, let's see. It goes up. And just take equation, baseline at the end of CO2 breathing, divide by the time. And we have index of so-called cerebrovascular reactivity index or breath holding index.
Is this the right side only?
It is left side.
I'm sorry, left, yes, okay.
Left side.
Yes, I saw that.
But again, as I mentioned before, I was not able with this new software to put right and left. Alright, so now on both sides we are seeing left side only.
In surgery, do they do both sides and everything?
It depends. It depends. For carotid endometrium,
Yes,
you need
the
to
side
do
that-
only
the
side
side,
of
yeah.
intervention. For cabbage, better to do both, right? Perfectly. And what we have here also, is it working for you?
It's okay.
So what we see here, mean flow, right? Oscillatility indexes, so-called resistive index 2, depth 50, which is normal, all right? And practically that's it during the surgery. You don't need to do anything. You need just to record. All machines, of course, allow you recording, and you can do offline evaluation too. Of course, all machines have certain markers. You can insert markers or do some other stuff. All right.
I guess you change the depth varying which artery you're trying to find.
Right, but again, during surgeries, we're mainly concentrating on middle cerebral artery, and it is depth 50, all right.
I just remember you said something about looking at the basilar artery and moving something at the frame.
Sure, you can do basilar artery too. Sometimes, again, mainly for if physician thinking about potential stroke, they can ask, and maybe stroke in posterior circulation, they can ask you, Alex, or so help, please monitor basilar artery for 30 minutes. And again, as I mentioned you before, we have CPT code for emboli monitoring, but not in OR. We have CPT for emboli monitoring with intravenous injection of microbubbles, as I described you for PFO determination. Right? And again, it's very easy test, but of course cardiologists would like to do TTE or TEE because $1,200, $1,500 charge versus $200. But it is more and more cardiologists using just bubble test. And in my former place of work at Hopkins, I do know that now for all stroke patients, they put bubble TCD as standard test for stroke patients. So patient arrives, it is IV 10 minutes test practically.
Dr. Spencer, he published some papers on using the bubble test for migraine.
Right.
PFOs.
Right. It is another very interesting area, but not very well developed. We had couple. This way. We had couple trials. We had couple trials run for migraine, but what established now is that how PFO was closed earlier, 10 years ago, it is open heart surgery. Now, researchers developed transcatheter closure device. It is a bunch of them on the market, so through the femoral arteries they're going to heart and just closing this PFO. Moreover, as I said, based on autopsy data, we have 26% of general population have still open this right abnormal right to left cardiac shunt. However, it is publication now saying that up to 40 to 50% of general population never closing PFO. And of course, not everyone who has open PFO will have stroke, but some of them can do it. Right? And majority of them are relatively young people. I do remember, for example, guy who was waiting, how it's called, lift waiting, right? 30 years old, very good, got small stroke. And we did bubble test for him and he had PFO. So it was closed later.
So we can monitor any intracranial artery?
Not any. Only arteries involved in the circulovirus. MCA M1, MCA M2, anterior cerebral artery A1 segment, terminal segment of the ICA C1, and of course we can do right left vertebral or basilar, but not all at once.
Fetal PCA?
Rare, but with diagnostic study, yes, you can find it.
And not PCA, just normal PCA?
Yes, PCA, yeah. From the temporal window, usually we're starting studies. Are you okay?
Yeah.
We're starting studying on right side or left side. We are doing M1, M2, C1, A1, then kind of directly probe more posteriorly, and we find PCA, P1, P2. A full complete study, diagnostic study, it is around 24 segments in the report format. Right? But not always you're able to find all of them. But at least majority of them, M1, M2, C1, A1, usually we find relatively easy. Of course, basilar artery, vertebrals. Questions for me? And of course, when we talk about PFO, for example, I don't know if you're familiar or not how cardiologists is done. They're doing injection of bubbles at rest, and then we so-called Valsalva maneuver. So you're asking patient, just bear down, all right? So patients bear down, and we again injection bubbles. For patient with stroke, for example, brainstem stroke, it's not easy to do Valsalva maneuver because some of them can have difficulty of breathing, and you can, when you put in esophageal probe, you cannot. And it is light sedation for patients, so they are not doing Valsalva well. But again, for patient fully conscious, as Esther now, is we can ask her to push down, for example, and you will see immediately changes in the waveform. So it's very easy to control if the valsalva magnon done correctly or not correctly. And it could be done in neurologist office, cardiologist office, I mean outpatient clinics, not necessary. So when I was saying, just hold your breath, but don't do it. Hold your breath and push down. No.
No, I was already doing it.
Sorry. Okay, let's start again. Just put down.
I was already doing it again. I'll do it again.
So just do. And look on waveform. Head down, head down. Like you can head it.
Just 3 more minutes.
So flow goes so flow goes down, as you can see. This normal. So flow goes down, all right, and you can control if the patient did valsalva well. So why flow goes down? Because increase in intrathoracic pressure, decrease venous outflow, and increase in ICP. Increase in intracranial pressure, and we are seeing very specific changes. So flow goes down, PI increases, etc., etc. All right. Questions for me?
Any second volunteer?
Huh?
I'm just asking if anybody wants to volunteer or want to try.
I don't know. Ask.
Anyone try? Any volunteer? You want to? This is your last chance.
I'll try it.
You want to sit down? Okay. Unmuted. We will leave a step now.
Thank you.
What's your name?
Andrew.
Andrew is big guy. Let's see how it will go now. But he's still young, of course.
It's fine.
I don't hear anything. I'm not hearing anyone in the room.
Do you want to try something?
When the signal comes through, it's not.
You can stand there. I guess
we have little bit small screens, and of course if you can monitor just one artery, we can change it, and we have just one of these screens through the whole display, which is much easier to see instead of two sides.
So when you do bilateral, do you typically turn the audio off at that point, since it would be overlapping?
One of the slides that you showed, it looked like the screen from Cadwell Cascade.
Yeah.
And it had the TCD schedule on it.
It was one display and different machines are feeding this display.
Okay, so it's compatible with some TCD hardware that you
TCD machine has video out. It has video out, so you can use the video in Cadwell machine.
Oh, so that was actually two screens just next to each other?
No,
It shows up in
it
the
was one
casket
display, and on this display several feedings from TCD, from infrared, and from others.
Okay.
Cadwell machine you can give two video
What do you
inputs.
want?
Basically, you have to have extra license. They give you have to pay for EG license, EMG license. So you can buy a license for video input. So you either just sell video cable, which is very expensive, or you can buy a video cable for $50. That's why temporary user because it doesn't have a video input. So you have to use a video to USB converter cable.
That's right,
It has RF connector or SVDO connector. Cadwell machine you can
especially for all
watch TCD, you can connect IoT connect.
so it's hard to find the signal.
I don't need to look at extension or you can see the screen and you're taking the picture or it's like time lock. Actually it's time lock. If you change an SSD you can drag the time frame and you see the camera. So usually all the microscope they have video out.
Like you talk about installation,
SVDO
you
That would be
so
really
that's
convenient.
normal stage. That's normal stage. That's
so much fun if you make tether cords. You don't know if really you don't need to ask them. You can see it.
Yeah, I always try to position my chair so I can see the screen.
You can also SPO like